Thank you very much for the opportunity to speak. With active surveillance, we know it's a preferred form of treatment for men with very low and intermediate risk tumor. This is endorsed by all professional societies. Its use, however, although increasing, is still quite variable. And I think its use may be limited because both patients and physicians are concerned that you've underestimated the cancer risks. They're called, you've got the tip of the iceberg. And genomic tests and MRI represent a potential option to improve risk stratification, and I'll show you the data from UCSF. There are 3 commercial tests at our disposal I was asked to talk about: Oncotype, Prolaris, and Decipher genomic classifier. Decipher is a 22 RNA expression biomarkers. It's really tissue from biopsy or radical prostatectomy, initially validated to predict the risk of metastases after radical prostatectomy. And in the report that you get, you'll get 5-year risk of metastases, 10-year prostate cancer mortality, and high-grade disease on final pathology, so-called adverse pathology. I want to point out that this is done on an Illumina chip. 22 of the genes that represent the commercial biomarker, but actually the company will share, certainly with centers like ours, a whole background which contains some prognostic markers. These are predictive. These are prognostic markers on grid. You can see some predictive markers: response to radiation and response to hormonal therapy. Prolaris, 46 genes, 30 cell cycle progression genes, tissue again from biopsy, radical prostatectomy. It was validated initially to predict death from prostate cancer with men undergoing conservative management. And most scores are between 0 through 10, higher score, more aggressive. And this report, as the Oncotype report, actually gives you a percentile compared to NCCN criteria. So you take the absolute score and you correlate it with NCCN criteria. Oncotype DX, again, it's a quantitative 17-gene RT-PCR assay. Again, these are the pathways that it looks at. And the report provides a genomic prostate score, GPS 0 through 100. Again, in the report, you'll get the absolute score, and that will be integrated in the NCCN category. I urge you to kind of look at the score rather than how it combines with the NCCN category. These tests have been recommended to be used in men with low risk and intermediate risk prostate cancer. Very low risk patients, you may not get a lot of additional information, but in low and intermediate risk patients based on NCCN criteria, I think this is kind of an ideal sweet spot to consider getting these tests. Again, it's been endorsed by various societies that actually MRI and genomic tests together may give more information, either alone or in combination compared to standard pathologic criteria. I'm going to give you one example. Okay, this is just using Oncotype DX. I could give you examples with Decipher and Prolaris. They have not been compared to head-to-head, but in my opinion, likely give very similar types of information. One important thing to realize is I'm showing you here the CAPRA score. Again, this is risk profile below on the bottom, 0 through 4, and the GPS score. And it's showing you that there's no correlation between grade and the GPS score. And what that's telling you is that the GPS score, the genomic score, is giving you some unique information. If you have a marker that correlates with grade, it's not important because you already have the grade. But this shows you that you actually get scores across different grades. And what I'm showing you here, again, this was an initial validation study done at UCSF on this biomarker, and I'm showing you the likelihood of favorable pathology at different CAPRA scores. Now, CAPRA score goes 0 through 10. So is 0 CAPRA is a very low-risk patient, up to CAPRA 4, which is an intermediate-risk patient. Now, that's showing you the likelihood of favorable pathology using standard clinical pathologic features alone: PSA, T-stage, cancer grade, and volume. Now, when you add the GPS score, what you see is you further substratify in each group of patients the risk further. So you can go either up or down using the Oncotype DX. Again, it's adding information compared to what you already know. And when you do use a marker like this, you actually will increase the opportunity to do active surveillance at least by about 25% more patients than if you hadn't used this. Again, in a multivariable model, again, I'm showing you Oncotype DX and upgrade on surveillance. We have 2,200 men on surveillance, and what I'm showing you here is that the biopsy scores, the biopsy volume at the time of GPS, and GPS are statistically significant predictors of upgrading over time. Interestingly, grade drops out. What drives grade is actually volume. we'll get into that when Mark and I discuss the next case. What I'm showing you here is a waterfall plot and the likelihood of progression. So again, blue is higher scores. And what I'm showing you here, that this is a range. So there's no one GPS score that completely excludes or predicts progression. So this is additive, not absolute information. You take this into account. You can have a high GPS score and no progression. You can have a low score and progression. But again, there's a clear trend towards higher progression rates with higher GPS. Now, this is data that recently published from UCSF where we looked at the likelihood of adverse pathology on surveillance. That means patients you followed over time who underwent surgery. And I've done about 450 radical prostatectomies in men who failed surveillance. And it's showing you that the GPS score per 5 units predicts for the likelihood of adverse pathology on the final specimen. That's either primary pattern 4 or 5 or T3 disease. But also for the first time, we're showing that, in fact, it may predict for PSA relapse, that a high genomic score at the time the patient's enrolled at active surveillance may predict for biochemical progression when that patient progresses to treatment. Again, a waterfall plot, and this time it's red, but the high genomic scores tend to predict for these endpoints. But again, there's no absolute GPS score that entirely excludes or predicts these endpoints. So again, it's additive, not absolute information. Concerns, tumor heterogeneity, that may not be a big deal because it turns out different than kidney cancer. When you take these scores from one part of the prostate and another, they highly correlate, suggesting that for prostate cancer, it's a field effect rather than individual tumor. Do all patients benefit? Probably not very low-risk patients, although for some patients, having an additional test that predicts for low risk of progression gives them more confidence to undergo active surveillance. Which low and favorable intermediate risk patients, are they cost effective, and what are the long-term outcomes? I do want to point out there are other biomarkers. PSA density, every time we come back at PSA density, it is a big predictor of progression on surveillance. So PSA density over 0.15, you really should take note of that. PSA density below 0.1 is a very favorable predictor of non-progression. P10 staining predicts for mortality as good as any of the genomic classifiers. Multiparametric MRI, what I'll mention actually in the next case is for all the pattern 4, you really need to get your pathologist to look at histologic subtypes, because actually these correlate with genomic profiles. So cribriform, glomerulation, fused gland, stromal reaction, all these are predictive and stratify patients further in this intermediate risk category. Risk factors for biopsy upgrade. We're trying to make surveillance less intensive. We really want to get away from doing biopsies. What I'm showing you here is upgrade at the first biopsy at 1 to 3 years, 3 to 5 years, and at 10 years. And what predicts for early upgrade are biopsy cores, PSA density, genomic score. Actually, PSA kinetics is not a marker of early, what we call misclassification, early upgrading. It does tend to predict for delayed upgrading. We've seen this over time where PSA tends not to change early on. In the out years, PSA becomes more reliable. PSA slope as a predictor of more advanced disease. In our studies, when we look at MRI and genomic, if you look at MRI, MRI does statistically significantly predicts upgrading over time. When we add the genomic classifier to that model, actually the PIRADS drops out. I think PIRADS is a problem because it's 1 through 5, it's 3 through 5. We really need to broaden the scope of risk classification with PIRADS. I think it suffers from that. There's a lot of data. I'm always impressed that we have a very high-tech test. It takes us a couple days to get the results, and then we take that test and we put it in front of a radiologist who scores it 1 through 5. To me, that's not high-tech precision medicine. We need AI, and groups like ours and Mark's, I'm sure, are working to improve this. So in summary, genomic classifiers are several commercially available classifiers, new ones being developed at UCSF and otherwise. It does add information to cancer grade, stage, and PSA. An adverse genomic profile should prompt reassessment or close follow-up, not necessarily treatment. So if you have a high genomic classifier, that's a patient where you want to do, I think, an early confirmatory biopsy. If they haven't had an MRI, you really need to get one. I think optional for men with, I think that actually the space that this works in is men with low and favorable risk disease. The signature actually appears relatively stable. When we looked at serial testing over time, it tends to stay the same over time. and randomized trials of these biomarkers are underway. Thank you very much.